Suicide Prevention, Awareness, Action and Support, brought to you by Mental Health at Work, a vertical of Equilibrium Advisory LLP. Before we begin today, a gentle trigger warning. Today's discussion will address the topic of suicide, including facts, experiences, and challenges that may be distressing for some participants. If at any point you feel uncomfortable, please feel free to excuse yourself and do take care of yourself. And during this discussion, your mental well-being matters most. Also, today's discussions are very crucial conversations leading up to the World Suicide Prevention Day, which is observed every year on 10 September. This day was established by the International Association of Suicide Prevention and World Health Organization. This day reminds us that, above all, suicides are preventable. And it unites communities, organizations, and governments around the urgent work of saving lives. This year's triennial theme is changing the narrative on suicide. It calls for much more than awareness. It invites us to step out of silence, break through stigma, and act with openness, empathy, and compassion. For those of us working in mental health, law, HR, and community leadership, this is just not an annual commemoration, but a profound responsibility to shape laws, strengthen support systems, and build culturally safe spaces where vulnerability is met with understanding and care. It is important to clarify that today's panel discussion focuses specifically on suicide prevention among adults. This focus arises because the causes, risks, and prevention strategies differ significantly between adults and children. Research indicates distinct patterns among children and adolescents with unique drivers such as academic pressure and mental health challenges that require tailored interventions involving multiple stakeholders like parents, educators, and child welfare systems. Our deeper focus on adults allow us to speak directly to the real world, multi-sectoral challenges impacting those in the workforce and caregiving roles, where social, economic, and mental health factors converge. The urgency is undeniable. In 2022, India recorded 170,924 suicides. That's one life lost every 3 minutes. Suicide remains the second leading cause of death for those aged 15 to 29 years, hardest among 18 to 45-year-old, the backbone of workforce and our families. Beyond these statistics are countless dreams deferred, families transformed by grief, and communities challenged to respond with compassion. And yet, every story of loss also contains the seed of hope. Hope that together, through honest conversations and collective action, we can help more people feel seen, supported, and safe. It is in this spirit of hope that I introduce our distinguished panel of experts who bring not just professional wisdom, but heartfelt commitment to this work. Dr. Dr. Jyoti Sangle. Dr. Jyoti Sangle is a seasoned consultant psychiatrist with over 25 years of experience, currently serving as a visiting psychiatrist at Holy Spirit Hospital, IIT Bombay, and SP Jain Institute of Management and Research. Honored among the top mental health leaders 2025 at the World Mental Health Congress and recipient of the Major Jennings Prize and the National Bhagwat Award, Dr. Sangle has published widely and leads mental health awareness through media, webinars, and support groups. Welcome, Dr. Sangle.
Thank you, Smriti.
Sachin Chidambaran brings over 15 years of experience in emotional support, active listening, and suicide prevention. As founder and director of training at the Connect Heart and co-founder of the Ankahi Suicide Prevention Helpline, he oversees 14 emotional support helplines across India through his presidency at the Befrienders Institute, a certified suicide prevention gatekeeper trainer from QPR Institute, USA. He has trained thousands in empathetic listening, drawing from a global volunteering background with Samaritans UK. Welcome, Sachin.
Thank you for having me.
Chetna Iyer is a project manager and research coordinator at the Center for Mental Health Law and Policy, ILS Pune. She's a social worker with more than 7 years of experience in mental health, crisis counseling, child rights, education, and anti-trafficking. Chetna integrates expressive arts-based and ecosystemic methods to empower youths in suicide prevention through training, facilitation, and capacity building for students, youth, and government stakeholders, driven always by advocacy and intersectionality. Welcome, Chetna. I'm Smriti Makarmedha, your moderator for today. As a psychotherapist and co founder of Equity Advisory LLP, my work sits at the intersection of mental health, law, and workplace equity. My intention for this conversation is to hold space for candor and care so that we don't leave with just greater awareness, but with resolve and practical steps that each of us can take in our own circles. So, by coming together, we are not only breaking the silence around suicide, but also reaffirm our shared commitment to hope, healing, and action. So, let's begin, right? And thank you all for being here. Just want to understand from all of you, all the panelists here, that what is the current landscape around suicide and suicide prevention from your focus and from your lens?
Who would like to start, shall we? So I think if I were to start, maybe I should start with what do we even mean by a suicide in the first place, right? Predominantly, whenever a suicide happens, our understanding of suicide is that it is an individual problem, right? Where it's either the person is weak or the person is probably doing a cowardly act, is giving up on life, taking the easy way out. And in some circumstances, it is also considered to be an act of courage. Now, this is the starting point where we will need to start questioning what suicide is. Because suicide is none of this, none of the above. When we have to understand suicide, first and foremost, we have to understand that there is a challenge that comes in right from defining suicide itself. So, for example, if you look at Google, the definition of suicide is when someone harms themselves with an intention to die. Now, unfortunately, when we say with an intention to die, it gets translated to the layman, it gets translated that the person is wishing to die, right? That intentionality turns, somehow we understand that to be wishing to die. And if this is our understanding around suicide, what will we do? We will simply ask the person, stop wishing upon this. Why don't you wish upon something better? But this is the complete ignorance around suicide. So to change that, first and foremost, we need to remove this ethical moral lens when we are viewing suicide. For example, when we have an accident, we don't put in any ethical lines or ethical lens when we view an accident. It's a truck accident, it's a accident by slipping, it's someone fell down the stairs, that's an accident. It's a train accident. We never distinguish, we call it an accident. However, when it's a suicide, we tend to, if we see, for example, the 9/11, this is a very common example I tout, where the World Trade Center, a burning building, and people were jumping from that burning building, right? Now, those people who jumped from that burning building, how many of us would call that a suicide, right? Most of my training, almost 100% of people would say that is not a suicide, Sachin, because you see, they were in a lot of pain and they didn't have a choice. That's why they jumped. How can that be a suicide? Now, precisely this is the challenge. Your problem is not with the suicide that happened from the burning building when people jumped off. Our problem is with every other suicide. What do I mean? For every other suicide, what we lack is the video of their pain and helplessness. That is the one difference between the burning building example and for any other suicide. Right? Now, the moment we are able to see that the person is in a lot of pain, and when we are talking about this pain, we are referring to is psychological pain. And when a person is experiencing extremely high levels of psychological pain, coupled with high level of perturbation or a sense of suffocation or an urgency to act, and in this volatile environment, there is a negative life experience that is added to the person, this is when a suicide happens. Suicide is not an impulsive act or something that just happens and it's there is no warning or there is no build up. These are the things, unfortunately, we have the modern psyche has assumed over time, and Bollywood or movies, shows and all have a lot to do in that sphere. So I think I would like to start that conversation with our basic understanding of suicide. Suicide is not a sign of weakness or cowardice or attention seeking or even courage. suicide is a symptom of pain. And if we are able to see that suicidal thoughts, any person experiencing suicidal thoughts, this is their mind telling them that something has broken, right? And the symptom, the way mind shows that something really bad has happened and you really need to get help, mind doesn't show it through our body. When I break my hand, it is going to hurt like 10 degrees worth of pain I'm going to experience, but I know what a body's pain is. But how does a mind tell you, express it to you, that I am in a lot of pain, that this particular resource or tool is in a lot of pain? It tells you you're not worthy. It tells you people would be better off without you. It tells you you are a burden. This is how suicidal thoughts are emerge for a person. And it is extremely important for us to understand that this is not the person wishing it or doing by their own side, that this is a phenomena that even the person is experiencing. So if I am someone who's experiencing suicidal thoughts, it will be a surprise for you to understand that even I am scared of these thoughts. This is quite literally one of the first experiences that a person has when they have a suicidal thought, that it might scare themselves. Like, what am I even saying right now? So imagine a person who's struggling with something and we blame it on them, that they are wishing it upon themselves. This is the major change we need to start building in. And obviously I have Chetna and Dr. Jyoti who will stress more on this as well, but that's my truth.
Maybe I can continue from where Sachin left off, and he's made a couple of really, really important points that I'd like to kind of continue on. One of the first things we also want to understand that suicides are a very complex phenomena. There is certainly that element of psychological pain and distress that the individual is going through, but we also know there is enough research and there is enough science to tell us that there are a lot of factors that contribute to that pain, and it is not really a problem with the individual, but it is often beyond the individual to say what are their interpersonal relationships, like what are the factors around them that contribute to that distress, to that feeling of that there is no other escape. What are the factors in the community, what are the factors in the institutions that these individuals live, work, and are a part of, and what are the social and societal level factors, what are the systemic factors. And hence we need to move beyond also looking at just this individual, sort of blaming the individual or sort of seeing it as an individual problem, and hence there is a band-aid solution to be done to say, if I do a workshop, or if I tell this person, or I put this person in a workshop to manage their stress better, it's not really going to solve the problem in the longer term. So there is also this need to shift, and say that there are systems around an individual which also contribute. And just to give an example and foreground this in the context of space as well. Now, um, in the workspace, there are a lot of things that also make that up, right? Like there is leadership, there is institution policies, there is the workplace or the organizational culture itself, there is the labor regulations, there are the welfare and social benefits that an individual can benefit from. And there is also a lot of the other things, like what are the dynamics, like what is there a grievance redressal system, are there reasonable accommodations made depending on who the individual is. So for example, if there are groups that belong to, say, vulnerable communities, like say persons with disability, or people from the LGBTQ community, or people from oppressed caste backgrounds, are the policies and systems in place that are supporting them? Are there individuals coming from very difficult life circumstances? For example, a female that is experiencing domestic violence at home may be held often to a higher level of productivity and standard just because of the organization culture and so on and so forth, without accounting for that fact. Or like a working mother, or single parents, or people that are pregnant, or so on and so forth, and various other factors that contribute. And hence, to really understand that suicides or mental health and well-being has to go beyond saying, hey, it's an individual problem and hence an individual has to be treated or fixed or cured, but also that systems can really play a part. Now, like you correctly said, the suicide rates in India reached the highest ever level, the highest ever number that we know of in 2022. Like that's where we have the data from, and we have, if I recall correctly, we have between the ages of 18 to 30. I think about 35% of young people end their life or lose their life to suicide, and in the age group of 30 to 45, there's another 32%. So that's 67% of our population that is dying to suicide annually, and this number is often underreported, or so we know that this number is underreported as well. So that is a very very huge number, and within that we cannot be creating only solutions or be looking at uh, individual sort of, or this sort of framing to say there is a problem with the individual, and hence how can we move away from that and talk about actually what groups. And I'll just kind of take a minute more before I pause to also say that within the workspace context, informal workers really contribute for the highest, almost I think 26% of total suicides that have been accounted for in 2022 are made up by this occupational group. And while we talk about workspaces, we often think about sort of white collar or blue collar employees, but we often engage with a range of informal workers in our personal capacities, in our homes, in our workspaces, through vendors or otherwise. And I think that is also a very important group to be thought through, and for policies and systems to be in place to prevent suicides there as well.
Thank you,
I think
Chetna.
yes.
No, go ahead, Sachin.
No, I think what Chetna was saying as well, right? Like the underreporting. I think I may be able to add a bit more light to that, and just the numbers, just to kind of get a contextual understanding how bad the situation is.
Yeah.
Right? When we are saying 1,70,000 over people dying by suicide, what do we mean here?
Yeah.
Now, Chetna spoke about underreporting. So NIMHANS has found, through their report, has suggested that almost 50% of suicides amongst women are underreported. And over 25% of suicides amongst men are underreported. What does this mean? It was not a suicide, it was an accident. It was that galti se kuch pee liya or something or the other. We always create these stories around suicide, right? And let's look at the impact. 1,70,000 people dying by suicide. That same year, we lost 1,70,000 people dying by road accidents, right? But for 1,70,000 people to die by road accidents, there were 450,000 road accidents. Have we thought about how many people would have attempted suicide that year for 1,70,000 people to die? You know what that number comes up to? By estimations, for every one suicide, there is 10 to 25 attempts. Now, 25 attempts, that translates to over 42 lakh attempts in that 1 year. 42 lakh attempts. But now let's take that one step further. For 42 lakh people to attempt suicide, how many of them would have to have suicidal thoughts? Because not everyone who will have suicidal thoughts makes that attempt, right? What is that number? That number is times 20. What do I mean? 8.4 crore people will have to experience suicidal ideation in 1 year for 42 lakh people to attempt, for 1,70,000 people to die. If 8.4 crore people are having suicidal ideation, can you begin to imagine how many people are dealing with mental health issues in our country? Right? And WHO has given us the number, 50%. Over 50% of Indians are dealing with mental health issues. NIMHANS has suggested over 15% of Indian population is actually dealing with psychiatric issues that needs hospitalization. 15%. So the ground reality is extremely bad. And while that is happening, can you imagine the underreporting that I just mentioned? It's the absolute worst. So India is the suicide capital of the world, where we are 18% of the world's population, but we account for over 26% of the world's suicides. So it's not even the argument that India is the most populated country and that's why we
Yeah.
have the highest number. So all of these arguments that we have very linearly put in place to kind of reduce the actual impact, or the conversation on suicide, how we are trying to break it down, we make it someone else's problem. It is not. It is our society's one of the major challenges that we have come up. And unfortunately 2022, as the last report, we are 3 years pending. 2023 report is pending, 2024 report is pending. So it almost feels like we are even scared to know what the next report is going to be like. So the ground reality is extremely bad, and we really need government, policymakers, and the organizations in our country to really get together and work in this space more.
Yeah.
Yes.
Yes, thank you, Sajid, for sharing those numbers, and I think they're very, very alarming and striking, right? And before bringing Dr. Jyoti as well into this, and from a mental health lens, because when you're really looking at it, I think that what I'm hearing from both of you, that in talking about suicide prevention, we can't localize the problem in the individual. It's a systemic problem that we're really looking at as well. It's very important that we separate the person from suicide right now. That it is not really a wish, but it's a response. It's a response stemming from helplessness, hopelessness, because the systems have failed them. Right? And when you're really looking at the vulnerability as well, like Chetna was also talking about, when you look at daily wage workers, elderly, people with disability, homemakers have been found the most vulnerable as part of the group as well. Because
Yeah,
why?
the
Because
second
even
largest demographic.
exactly, that's the demographic, and the access is not there, right, to support as well. When you're having these training programs also in organizations, as all of you would be aware, seldom we look at blue collar workers, daily wage workers, part of those programs as well, right? It seems like this is not our responsibility. Or when you're looking at homemakers also, where is the access to support? In fact, just yesterday or day before, I was reading one news article as well, where the husband forced the wife to jump from the second floor, and then she actually jumped in front of her child, and after jumping, then he beat her up. And when we really talk about domestic violence, it's just one of the cases. Or we talking about there's another case that you were talking about, how this person uh, so was looking to cross the rail line, and said it was an accident, but it was not. And there were enough and more indicators of that. And I think here is what I want to bring Dr. Jyoti, because when we are looking at as mental health professionals, we do look at the gradient as well. We spoke about ideation, right? It's ideation, then looking at, have you thought about it, right? Then has it been an attempt, right? And we know that if there is a past attempt, the risk is very high in those cases. And it's a gradient that we're really looking at as well at this point in time. If there's been attempt, multiple attempts with the intention to hurt themselves also. I mean, looking at intentionality again, not as like a wishing, but the fact that they've been trying so hard to really cope in that situation, but finding themselves completely alone in that situation, right? And that's when they're really reaching out to people, how they're really responding to that. It's an attention seeking behavior, it's a passing phase, right? Or they're just so consumed with their own anxieties of not really knowing how to respond to the person as well, right? And then when people are dying with suicide, and then there's a whole legal lens to it, how earlier it was considered as an offense, right, which has obviously changed under the Mental Health Care Act, and I would like to bring Chetna in subsequently as well. And when you're looking at interventions that really look like, how are we then talking about through WHO, removing access to means, when you're looking at lethal substances also, making it difficult to procure it as well, having those rail guards. So there are these means that have also been put into place. So I want to really now bring in Dr. Jyoti Sangle here to talk from your position as a psychiatrist, when we are interacting with individuals, families, caregivers, and the systemic issues that you're noticing in your consultations as well. And then I would really like Chetna to come back in to talk from the policy perspective and the legal lens perspective as well. Dr. Jyoti Sangle.
Good morning, everyone. It has been, so we've heard the extent of the problem, and I think we've been able to underline it and emphasize it to a big extent. And the message, I think, should have gone across that what we are dealing with is a very important, maybe burning problem that we need to kind of look at on medical, clinical, social, and economic, professional, every possible platform. that this needs to be a part of any policy, any any intervention, any health plan, any insurance policy. This needs to be a part of, because that's what clinically in a hospital setting or in a clinic setting do we see. So I'll try to cover each one of them gradually. So suicide, by the word itself, comes from the Spanish language, where it means cry for help. So whether it's an intent, whether it's a thought, whether it's an attempt, whether it's a completed suicide, it basically means that the person is crying for help. Now, this help is obviously psychological help. So, when we are talking even of self harm acts, which are very, 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 very common amongst the youth in today's date, and is increasing by leaps and bounds as their coping mechanism to pain and their coping mechanism to instant gratification of what they want, their coping mechanism to the low frustration tolerance that we are seeing in the upcoming generation. All this engulfs a cry for help. The cry for help does not necessarily need to come from clinical anxiety or clinical depression or clinical schizophrenia or clinical OCD. Yes, it does come from there. But I would say that is 25% of the attempts or the thoughts that we see in a clinical setting. What we see more is the inability to cope with their circumstances, maybe with the system, maybe with their home situation, maybe with traumas that they have been through, maybe their own relationships, romantic, friends, their their very deep sense of FOMO in today's date, the fear of missing out on something. So their entire cry for help is coming from there. So being a part of two educational institutes, I would say it's difficult for them to cope with the independence, both positively and negatively. They're very happy to step out of the house and be independent and have their own world. But because they have come out of a rigorous coping coaching setup, they lack social skills. So they come into a room, but they can't handle the loneliness. They can't handle the daily chores that they can do. Even something as simple as that can offset them to have a cry for help. Even as something as simple as somebody not speaking to them in their canteen can cause a fleeting thought. Even in a workspace, we see people not being able to handle the pressure from the work stress, from the bosses, from a work life balance, from a family perspective. So, the things, the causes need not be very clinical and major. The causes can be something out of daily life. But where we are lacking is the social skills and the coping skills. So we are not, so when we're talking about self-harm or suicide, we are not really talking only about the hospital is the point that I'm actually trying to emphasize. We are not talking only about a mental health studio or a mental health clinic or a psychiatry OPD or a psychologist's cabin where self-harm and suicidal thoughts exist. They are existing in people walking on the road, be it a student, be it a bank employee, be it a corporate person, be it, like she said, a housewife or whatever. So what I'm trying to say that the settings are very, very normal. So it's time that the narrative behind this cry for help is widened and is kind of accepted as it's okay to discuss this. And not every time that a person says that I am having a cry for help or I find life not worth living like this is does not equate to a suicidal thought. it's important for us to encourage those discussions in a clinical and a non-clinical setting and guide them towards help. Most of the times, a client or a person will not remember our names, but will definitely remember how we made them feel. So even in a clinical setting, in an educational institute where I go, so now if I go to the hospitals, if you talk about a hospital OPD, okay, in a casualty, in a hospital, one singular hospital casualty, we would have at least 5 or 6 suicidal attempts in a day. So imagine the number of nursing homes and the hospitals and pan India, right? So we are talking about things which are coming up, which, yes, have clinical depression, have clinical anxiety, but quite a few times it's not as bad as that, as to require psychiatric help. Talking about the neurodivergents, talking about the special populations, their struggles by itself are very unique. And if we don't encourage inclusivity in the workplace, if we do not give them an ear where they feel they are heard, they are not heard in a hurried way, they are not heard for the sake of being heard, we can actually navigate that. That's a very that's a setup which is very negotiable, and it can be navigated. But because of the inclusivity which is not coming, there is a lot of problem. You go to a university setting, the way a neurodivergent is treated at times, the lack of knowledge amongst the faculty, which is on the other side and which is now our generation rather than the next generation, which is very neurodivergence aware, and the ridicule that they have to go through, and the non-acceptance they have to go through, and the policies in the website not being in place. It's very frustrating for the students because they are so sensory hyperstimulated, but they have no respite from the educational institute. That's not fair to them. So these are factors which we see in clinical practice. Now, if I have a person whom I'm diagnosing as ASD, but in an educational institute, I can't offer him a single room. What have I achieved? How will he function? So he can't function. He will go and do something. So for them, the settings are, it's a survival instinct for them. And once they feel that we can't handle this, we won't survive this, they reach out to self-harm. They reach out to, because it's very difficult for them to go back and tell their home that we are not being able to manage this. They feel obliged for the amount of effort the family has put into them. Or it's the same place which is trauma triggering for them. Very common in today's date. Or they kind of take it upon as, I have been a failure. And the sense of failure, the sense of it will not happen, I will never be able to make it, is underlying these attempts. So I would say, yes, I am a psychiatrist sitting in a clinical setting, but very honestly, yes, we will see a lot of psychiatric illnesses and I would say pathology behind these attempts or thoughts, but a lot of it is much simpler, which can be handled before we reach a psychiatric diagnosis.
Yeah.
So I think the verbatim needs to change there, and that will help.
Yeah. I think some very key points that you have shared, Dr. Jyoti, here, and I think I just want to really sum it up also, because I think we know that suicide is a cry for help, right? And I think that's the theme that we've been really talking about. That's how the change really needs to happen in the narrative right now, right? It's a response to the helplessness, hopelessness of the system really failing them as well, right? The other thing I'm also hearing from you, that we know that suicide is symptomatic when it comes to, say, depression, anxiety disorders, and it's a response to that. But when you're also looking at the fact that people having these suicidal ideations or living with it is also people like you and us at this point in time right now. And if we have to really prevent suicide from taking place as well, we need to be constantly listening. And I think that's the work Sachin does also through his trainings right now, when people are saying that, life is not worth living. What's the purpose of my life? I don't think anyone loves me, right? When they're making these statements, that's saying that it requires an intervention. They may not be experiencing suicidal ideation, but the fact that an intervention is needed at this point in time right now. Uh, right? If I'm not here, no one is going to miss me, right? I'm a burden. When these statements are being made, this is it itself is translating into that cry for help as well right now, and which further, and this pain, the psychological pain that we're talking about, is so immense. And that people result into self-harm behaviors. Like my clients in my therapeutic space have told me that when I cut myself, it's not with the intention to end my life, but it helps me distract me from my psychological pain. That it's my only way when I make that cut that I'm able to numb my psychological pain and distract myself, because then my focus shifts to this physical pain. Because otherwise there is nothing else which can distract me from that pain and those thoughts.
And they
Right?
are then able to take care of that wound. So they are able, because they are feeling this pain, there is a wound inside, but it's a
Yes.
wound that I'm not able to, point a
Visual.
finger
Yeah.
at, right? I'm
Visual.
not able to put a band-aid on that wound.
Absolutely.
So
It's like
what
a
do I do?
plaster, right? No band
And
is
this
going to
is
help at that point in time.
exactly, and this is how, like, for regular people, understanding that this is how you treat headache. When you have headache, you put a burning balm on your forehead. Why? The balm is not miraculously curing your headache. It's just burning your skin, which is distracting your brain from the headache to the burn,
Yeah.
right? And this distraction is experienced as a sense of relief.
Yes.
There is also some dopamine release that the person can experience at this. And I'm pointing this out. Why? Because NSSI, the non-suicidal self-injury that we are talking about, very often can also turn addictive,
Correct.
Yes. Yes.
because the pain is so constant, and that they have used this method to help them. Again, that coping mechanism that doctor had spoken about, that coping mechanism, when I do not have any resources or am any skill to mitigate this sense of discomfort that I'm experiencing, and somehow if I got an injury, I could see that I sensed relief. So there is this another point of view that, oh, it's the blue whale games and other things that are training the youth. No, this is an emergent behavior. Like
Yeah.
self-harm is an emergent behavior in any society. No training is required. And if in your space, if one child, adolescent is doing it, the chances are almost 20% of children in that space would be self-harming, because
Absolutely.
dysphoria travels extremely fast amongst youth, amongst children. So it's not, again, this trope about they are this weak, the children, the younger generation is weak, or we have to really really educate ourselves as to what are they facing, when they look at the world, what are they seeing, what are they experiencing. And obviously this is the same thing that we need to do for adults as well, because everyone's life has changed. There's a digital revolution or a digital disease that is spreading around, and we all are bound by it as well. So
Yeah.
it's extremely important that we get these perspectives in place.
Absolutely. And while we're discussing
I
this, right?
would
So,
also, just a small thing, I would
please.
add to Sachin's comment that they are also extremely impressionable.
Yes.
Extremely. So it's almost like, so he spoke about the dysphoria being rampant or spreading fast. I would say it's even a herd mentality that she got or he was relieved of the pain. I will also try, and today I will just try and keep my coping mechanism ready. Clinically, this is very, very rampant. I just tried because I saw her trying it. So I just tried. But then the relief was so good that fantastic. This is almost like somebody was on Ritalin and I tried taking a Ritalin, whether it improves my concentration or not. It's literally of the same kind. So we have people coming into our room and saying that, okay, this one tried Ritalin. We also have people coming into our room and saying that, doc, none of your medicines are working as much as cutting myself has worked.
Yeah.
So there is
And
also this experimental thing, this wanting to have an adrenaline rush that concept is also very, very, it's catching on very fast, and it's scaringly catching on very fast. To be very honest, as a clinician, I would be concerned at the rate at which it's catching on.
Yeah.
And the
Right.
underlying challenge from this is if there is addiction as well, because you can get addicted to this process as well. What is happening? The worst thing that is happening is the person spoils their relationship with pain,
Hmm.
if that makes sense. My relationship with pain is we have pain as a mechanism by our body and mind to put an alarm. It's essentially to put an alarm to tell you which part of your body or mind needs help. So pain is a mechanism that is there to, okay, hand is hurting, pay attention to the hand, right? It's broken, so it will hurt 10 degrees, so that you put that priority on that hand. So pain is not bad. Essentially, pain is the alarm system of our body to help us mitigate whenever anything breaks down. But imagine now if I'm slowly building up my threshold to pain, which happens in NSSI. And unfortunately, what this results in is accidental suicides. That rate can also increase. So there may be people dying with where there was no intention to die as well. Again, not wishing, but an accidental death can also happen because their relationship with pain has gotten spoiled so much.
Yeah.
So that's kind of just want to
And that's
point
true
that.
even for overdoses. The
Yes,
Yes.
exactly.
pill overdose and the poisons that so the pesticide ingestion which we see in the housewife segment or the
Yes.
domestic worker segment, which Chetna very beautifully highlighted. So that section, it's impossible for them to know what quantity of pesticide is experimental and what is really lethal. Even in medicine overdose and pill overdose, which we
Yes.
unfortunately see maximum in the medical workspace, and we unfortunately really know how much of it is lethal and how much
Yes.
of it is not.
Yeah.
That's It's really scary. It's
Yeah.
so what, taking forward what Sachin is saying, the experimental and the crossing the fine line can get very, very tricky.
Yeah.
It's quicksand on which we are walking there.
Right. Yeah.
There's
So
just, sorry, go ahead.
Yeah.
no, I was just going to sum up this discussion and then bring you in, Chetna, if that's okay, unless you have a point
I
to make in addition
Yes.
to what you. Please go ahead.
Yes. So just to highlight and draw upon that, I want to also talk about how the role of media in perpetuating this sort of contagion and how we talk about suicide matters, right? Like,
Yeah.
are we being very overly sensational about it? Are we talking explicitly in graphic details about the individual, their circumstances, the access, the means, and so on and so forth, really does impact how people who are in distress respond to that piece of information. Like, how do we talk about suicides in our communities, in the media, in the society? All of it matters. Whether we talk about it, don't talk about it, all of it matters, right? And there is also evidence to say media reporting, sensitive media reporting, can reduce suicides by, I think, up to 2% almost. And whenever we see that, whenever there is a death of a public figure or a celebrity and the media is going on and in graphic detail and all of that about it, it always increases the number of people who've attempted and died by suicide after that. So that is also the contagion. And here again, shifting the focus to say from the individual to the system, to say that how these things that happen in the community and in the social environment of the individual do impact. And in fact, there are guidelines on how media should be reporting suicides, in both print, digital, news format, social media, and so on and so forth. There are guidelines on how we should be talking about suicide on social media, as well as in terms of universities, because that was a very vulnerable sort of group or a high risk group in our country. Also, how are institutions handling cases of students attempting suicides or death by suicides? Are there measures in place to address and support the individual who's attempted, or the family of individual or the student who's died by suicide, as well as all of those who are left behind, all of the students, faculty, non-teaching staff, because it certainly has an impact on everybody. So these are called post-vention measures, and there is very much a need to be
Yeah.
sensitive and grief affirmative, and like Dr. Sangli also said, trauma affirmative, to really address this, to prevent the other folks who are in distress to be pushed to also attempt and die by suicide. So that was the point I wanted to add. And I know you wanted me to like talk about law, so I would like to actually take this opportunity to quickly make that linkage here as well, if that's okay. Yeah. So now, one of the things here is when we talk about how do we talk or how do we not talk, one thing we also can acknowledge very obviously is that all of us know someone who's died by suicide or attempted suicide or has been impacted by suicide. Like in large rooms and halls filled with people, if you ask a question of how many of you know someone or have experienced yourselves, or how many of you don't know someone, rather, not a single hand will go up. Yet there is a lot of hesitation in talking to someone about it or being a part of it. So now, drawing from what Dr. Sangli said and Sachin said, is that suicidal thoughts can happen to anyone. It can happen to you and me, right? And we all know someone who has been impacted, or we ourselves may have lived experience. Now, the good news in all of that is that suicides are preventable and all of us can play a role. I think that is uh, really important to understand, and we don't need to be mental health professionals to be playing a role in preventing suicides. Employers, employees, colleges, institutions, workspaces, each of us can play a role, and there is a whole body of evidence around training people to be first responders or provide sort of lay emotional support, and training managers in skills for in gatekeeper skills for preventing suicides, and so on and so forth. Now, just to bring this contextual this sort of and contextualize it in the framework of law policy in the country, um, I'd like to start by highlighting the Mental Health Care Act 2017, which decriminalizes suicides, which means before 2017, anybody who attempted or died by suicide could be penalized for that. But the MHCA, which is the Mental Health Care Act, decriminalized suicide, which means people that are attempting suicide are recognized to be under severe stress and severe distress, and they in fact need care, support, and adequate provisions that will help them manage the stressors, rather than penalizing them or treating the attempt or the death as a crime. And there is also provision. The mental health care is also rights based. Like, it takes a rights based lens, which means that everybody has the right to access appropriate, suitable, acceptable mental health care and treatment at government facilities, and these facilities must be affordable. They must be accessible. It should be of a good quality, and so on and so forth. And this includes the context of workspaces as well. Now, also to bring into conversation the rights of persons with disability act here. Mental illness specifically is recognized as a disability, and this shift happened with this act, which came out in 2016. And one of the things it does is it guarantees the right to employment for persons with disabilities in public and private sectors with reasonable accommodation, which means that depending on what the challenge of the individual is, there needs to be a reasonable, proportionate accommodation made so that they can effectively participate in the workforce. And that means that, for example, workspace need to be accessible. There need to be non-discriminatory practices, including for persons with physical disability, but also those with psychosocial disability. And there should not be discrimination, say, in recruitment, in promotion, or retention of persons with disability. There needs to be the physical infrastructure as well as policies that are affirmative and encourage the participation of persons and do not exclude persons with disability, right? And then finally, the National Suicide Prevention Strategy. Here, there is this came out in 2022, and this also came as an effect. All of these laws and policies have come due to a lot of advocacy by persons with lived experiences, social workers, mental health professionals, families and caregivers of persons impacted. And the National Suicide Prevention Strategy basically talks about integration of mental wellness programs and facilities in the workplace, and also protecting rights of vulnerable and marginalized groups. And there are certain sort of high risk groups and vulnerable populations that are also recognized, which will include, say, informal laborers, persons from marginalized or oppressed communities, rather, students that are transitioning into the workforce, daily wage laborers. In India's context, it would also be agricultural workers, farmers, and so on and so forth. And they're especially mentioned because of the increased vulnerability or the increased risk they have because of economic stressors and occupational stressors as well. Now, there are different sort of ministries that are tasked with the responsibility for ensuring that these guidelines are implemented and so on and so forth. But I think there is a long way to go as well in terms of what gets translated into practice. But really, I think if we can take something away, it is to say that there are certain laws, policy strategies that are in place, which does put the responsibility on systems such as workspaces to ensure mental health well-being, prevent suicides, take affirmative actions at the institution level to prevent suicides. As well as, I think, as individuals, if we can take away that it is not a crime to be attempting suicide, and there is often this a lot of fear that if I talk to someone and they tell me that they're having suicidal thoughts, I will be in trouble. And I just want to clarify that that is not the case. um, and there
I'll
is a
just
lot of
add.
recognition. Yes, I was just going to hand over to you. I just wanted to say that there is recognition at the law and the policy level that suicides are a result of severe distress. Yeah, over to you, Sachin.
No, I think Chetna has brought up that point brilliantly, right? That the Mental Health Act has decriminalized suicide. However, on ground, you may experience slight dissonance. What do I mean? If there is a suicide attempt, there will still be police reporting it. They will still put it as section 308 or 309. They will still, you will
Do a
have to
medical
go through
legal
that
report.
process. Right. But so there is this big confusion on ground, like why are the police involved when you have called it decriminalized, right? Now this is the difference we need to understand. Like in India, the tracking of suicides or attempted suicides is being done by police. The NCRB, which collates the information and makes the ADSI report, the accidental death and suicide incident report, that information is being collated through these police chowkis, and that is getting transferred upstairs and where the collation is happening. So there is no independent NGO, which is another one of the recommendations for the National Suicide Prevention Strategy, that instead of the police tracking the attempts and suicides, that it should be moved to an independent NGO or organization where, because police is coming into touch in these situations, there is this assumed criminality over there. And hence, if we are able to move it from them, so if you're a doctor, you get a client who is showing suicidal thoughts or has attempted, sure, it will be recorded as a 308. However, they will not be punished for it. Earlier, the law would have stated that they would have had to pay 500 rupees or a 3-day imprisonment or. That was also aimed to kind of seclude the person, isolate the person, and not allow them to die. But it was a very weird way to show concern, I guess. But now that you will not be jailed or there is no fine, that is the decriminalization part. However, police will will make a medical legal case and report it. So just that bit I wanted to add.
Right. I think a lot of important discussion that are happening right now. But if I have to really now sum it up from what we're discussing, and I'm going to keep bringing it back to how suicide is preventable, because I think we need to understand this, and that's the change in the narrative that needs to really take place. If we really want suicide prevention to be effective, we need to understand that there are multiple stakeholders here. One is the individual. Then you've got multiple systems in place as well, the education institutions, families, teachers, faculty members, media, houses, organizations, police. And then we also have the government bodies and the policies and the laws that are in place as well, right? And when you're really looking at the individual, and going back to what Dr. Jyoti Sanghi was talking about, one is, I think, the person who is experiencing that pain, right? And how are we really empowering them with coping, effective, supportive, healthy coping and social skills right now? Because in the absence of that, they could result into non-suicidal self-harm injury practices as well, NSSI, the self-harm behaviors, dependence on alcohol, drugs as well. And we are also looking at how the relationship with pain is constantly changing with them. In our mental health, also say about how the tolerance levels keeps on increasing to those substances as well, or to that physical pain, and how the risk also keeps on increasing in these spaces, right? And to really be able to empower them, we need to understand when they are experiencing the sense of emptiness, worthlessness, right? It's okay to reach out for help, to speak to a therapist. Having these skills where we're empowering them with these effective skills also, right? Then we're also looking at when what are they really, who are they really reaching out to? Now the chain that we're really looking at, what Sachin you were trying to mention about this new digital era, people are reaching out to AI tools. We have had one of the cases that came out in the report recently also, a young person, 16-year-old, who died by suicide to the extent of having multiple mentions. So almost there were about 600 mentions of self-harm behaviors. And on the contrary, there were 1,200 mentions by the GPT, and to the extent that they had also gone ahead to show even images of how they were looking to end their life as well, and there was no escalation that was there, right? So we're really looking at how people are, who they're really choosing out to, who are the trusted adults, trusted sources now. And unfortunately, they're not clinicians, they're not parents, they're not peers, but it's becoming these AI tools, right? And that's again a space I think which requires extensive conversations. But I'm going to pause there, not really get into that space, but really looking at the systems that we have here. When you're looking at family members, and I think Chetna also spoke about this, right? And when someone discloses these ideations to us, how are we really responding to them, right? And how are we really equipping family members, peers, and how do you really respond to those situations? I want to really deep dive into that conversation right now. Education institutions, people are not really aware of neurodivergence, or when you're looking at protected groups as well, their lived experiences, what are the unique life stressors, and how they're feeling unsupported as well. So, how are we then looking at empowering people, which is going beyond the conversation on suicide, but really equipping them in the diversity of experiences also among families, peer support, education institutions, and then you're looking at media houses, organizations, and we know that WHO has come out with very strict guidelines around it as well to support them to how to even have these conversations as well. But are people aware? So, firstly, and if they are aware, do they have access, intention, resources? Because whenever they are going to be, budget resources have to be reallocated, reconsidered, the first thing that gets pruned are all of these initiatives coming from DIB or mental health as well, right? Which really takes back to what Dr. Jyoti Sang is talking about, that people are responding to this because they're not feeling included in the system. They don't feel that they belong here. That's why they're a burden, right? So then how are we really bringing the sense of belongingness for everyone in the community, right? Someone living with mental health concerns or someone not living with mental health concerns, but just feel that they're not fitting in at this point in time right now as an individual or as being part of a protected group. And then lastly, we are really looking at the larger systems of government bodies, international bodies, and you have these policies in place, laws in place as well. We have made a shift by decriminalizing suicide through the Mental Health Care Act as well. But when the police is really coming, what is the kind of tonality that gets adopted? And that's very problematic, we know from our experiences also, right? It's almost like putting the other person down and feeling them guilty for taking that action, and almost feeling like the fact that you need to think better, you need to think beyond yourself also. And I think now what I really want to bring in this conversation, while we understand the different stakeholders, where is stigma that sits in through all of this as well? Because I think that is still a very big barrier that we are facing when we are having these conversations either with individuals, systems, and different stakeholders. Stigma is still a very big part of it that sits in that conversation, in that space. So, in your experience, all of you, Sachin, Chetna, Dr. Sangle, where is stigma in this part of this landscape?
I think when, for example, this is the thing, even people who have been working in this space for years, for example, in mental health space as well, the anxiety that even the mental health professionals experience when they have to deal with a client with suicidal thoughts, it's unbelievable. Like, just to kind of point out, over 75% of American mental health professionals do not have a formal training in suicide prevention or understanding of suicidality and helping out. Now, we just need to understand if that is how bad it is in US. We are still a country which is, finding its foothold in the mental health space. So in India, this number is over 95%, that we do not have a formal training in suicide and suicide prevention for mental health professionals. First problem. over 90% of mental health professionals in India have clients with suicidal ideation. Now look at this discrepancy that is existing. Now, where is stigma? Now consider this conversation that I may have with my wife. If I have experienced and I'm going through a lot, and as a result I'm experiencing suicidal thoughts, now what will it sound like? And if I were to ask for help, what would that look like? Now I will tell my I don't think I can go on like this. I don't think life is worth living anymore. I'm having suicidal thoughts, right? If I were to just say this, what is my wife going to think now? One of the first responses she may be having is, what did I do? Was my love not enough for you? What is it that is causing you this? So do you see, the first thing that we do is look at the external environment, and we're like, or ourselves, because suicide almost sounds like the challenge is suicide brings with it guilt, shame, all of these feelings, right? And when someone is sharing with me and telling me I'm having suicidal thoughts, what we are hearing is this is a time bomb about to burst anytime, and somehow this person is blaming me. So am I then able to offer compassion to this person? Because stigma lies here, where when we see pain, when someone is crying out loud in pain, what is our response supposed to be? As Indian culture, it is ingrained in us that when you see pain, offer compassion. This is, automatic. It's our response. But the challenge here is we are not seeing it as pain. That's where the stigma is. We don't recognize it as a pain. What we see it as is a complaint, a means of blackmail. It's a means of attention seeking, and we haven't moved beyond that. And that is where stigma is, I believe. But obviously, it's a bigger conversation as well.
Should I take it forward?
Yes.
You okay?
Go ahead.
Okay.
Yes.
Yeah. So I think, yes, what Sachin is saying is one aspect of the stigma. The other aspect which I feel is uh, it stems from the basic stigma against mental health. That's where it basically also stems from, that a student seen outside a counselor's or a psychiatrist's OPD is different. In a workspace, if you have employment assistance programs, which you should have, and many of them are now taking it up. But if you're seen outside the counselor's room, what is happening? Now the risk of saying that the workspace is not mental health conducive to me, will that affect my job, comes from an underlying stigma which the hierarchy may have. In a school, if I say that I find the teacher insensitive to my needs, am I going to face punitive action after that I will lose even more marks? If a lady says that I am not being able to adjust in a household after marriage, but she cannot go back to her parental house, is this going to be worse for her? So it's coming out of the basic stigma for mental health, that you are, like he said, weak enough to not be able to cope. So according to me, the usual acronym which I give everyone, one of the ways to handle this is something called OASIS, where the O stands for trying to develop an open culture, an environment where we encourage confidential, very, very open mental health conversation, having a mental health vocabulary. We develop an open culture in a workplace if we can, by maybe selecting a few at each managerial level and making them mental health warriors, making them mental health, call them mental health champions. Like They're given a certificate if they reach a particular mutual fund engagement target. They are given a certificate if they get so much of investment for the bank. So the bank guys are the most burnout. According to them, they're the worst. But they are given these certificates, right? If you reach this target, you do this. Give them a target of maybe identifying 2 people who have mental health problems and call them a mental health champion. Maybe that can be a step where you can manage the stigma, create your own within the organization, create mental health warriors, mental health champions, mental health advocates, whichever word we want to use for it. So that's the O that I talk about usually, an open culture within an organization. Not a very easy thing to do, but definitely a basic step by having an EAP in place, having a maybe mental health Friday where you are allowed 2 hours to do whatever you want to do, or giving them flexi hours when they ask for it by finding out why they want the flexi hours. I do not deny the fact that these things are misused in our country. I do not deny the fact. But it, because people misuse it, the ones who need it cannot be denied the help. So that's the O that I talk about. The A is awareness. So when we, if even in organizations, when we do that, okay, we have a mental health awareness talk today, 99% of them are muted with their video off. They are completing their work to go back home or to log out of this. क्योंकि we are going to tell them how to identify anxiety, how to identify depression, how to identify this. वो हमको ज्ञान देंगे and we will go back. My point is create an awareness at a very grassroots live sessions. Tell them that your fluctuations in performance can be a reflection of your mental health status. Your fluctuation in your physical fitness or motivation for your physical fitness can be a sign of mental health fluctuations. You not being able to maintain an eye contact with your boss could be a sign of your mental health status being fluctuating. You're not being able to maintain a daily work-life balance could be an indicator. Is an indicator? No. Could be an indicator. Your engagement in work, your poor decision making, your inability to make decisions, your indecisiveness, you're not being able to deliver your targets on time, you're not responding to mails on time, you're not wanting to come to work, could be a reflection of something which could be encompassed under mental health. At least try to explore it. That's the kind of awareness if we can create, it makes sense. Then the S, support. Actually have practical support there rather than just saying we will support mental health. It's no point doing that Mumbai Indian flag there. It doesn't work. What works is if you can actually create a support that if someone comes and tells me, I will refer you to an EAP, I will refer you to an MHP, and I will keep this confidential. And I also do not want to know it. And I will financially reimburse this for you. Half the times, mental health help is not sought because they cannot afford it. So that's kind of an S which we can offer. OAS. The I. I is actually intervention. Like Sachin said, can we create suicide gatekeepers within the organization? Can we create people who can help people just talk, feel them heard? Doesn't have to be an MHP. Just figure out that, okay, may need EAP, may need mental health help. Even that much of intervention at each managerial level can go a long way. And this is not creating a separate cabin within the same floor that anyone who's entering that cabin, there is something wrong. Keep it very, very open. Keep it like a coffee chat, or keep it as something which is a music room or a table tennis room, and somebody is having a tete-a-tete. It's okay. And the last S is actually stress busting initiatives that I talk about. So have on a Friday, let there be a lunch which everyone goes for. And everyone can go to a hanging out room when everyone is sharing a common music interest. So you can have a Kumar Sanu room, you can have a Hariharan room, you can have a Radiohead room. Just let people be for an hour on Friday. Let them do what they want to do. Give them that stress busting initiative within their working hours, which is not unpaid, for which their payment is not cut. They are not said you're unproductive for that 1 hour. So that's another those are the kind of stress busting initiatives with the warning signs that we can kind of maybe pick up. But yes, what underlines the whole thing is confidentiality. What underlines the whole thing is comfort. What underlines the whole thing is communication. That there is a sender of a communication piece. Somebody receives it, gives a feedback, gives it to the sender. So sender, communication, receiver, feedback. Now this loop has to be on. If this loop is broken anywhere, then there is an issue. So if we can keep this loop going, there's a good chance. Okay, let's put it this way. In a year, even if we can prevent one self-harm act, we have achieved something. I am not looking at one a day. One a year after this seminar, if we have made a difference to one person in 1.5 hours, we have achieved a target.
Thank you, Dr. Sangli, for the OSS. And I see there is a C as well, C for confidentiality, comfort, communication, and care. I think that you
Three
also spoke
C's.
of.
Yeah.
Yes.
Yeah.
Yeah. Chaita, I want to also bring you in.
Yeah. Thanks,
So,
Nidhi. Very, very quickly, kind of adding on to what Dr. Jyoti and Sachin have already said. Um, so some of these things in terms of, I am also just seeing the comments. I was also just seeing the comments on the site, so I'll also just take this opportunity to respond very briefly to some of them, which is that there is a lot of evidence-based work that we've done or we've been doing around training people to draw upon their own experiences and their own lived realities to provide support. And for that, you don't need to be a trained mental health professional or anything like that. We need to kind of move beyond awareness and knowledge and say that, okay, we did one workshop today and now that's it. So that shift from shrugging off or denying responsibility to actually moving into a skill based strategy at an institutional level to ensure well-being, like Dr. Jyoti said, at multiple levels. So how can we train managers, for example, to recognize warning signs and respond? How can we train employees on a day-to-day basis to respond better to everyday stressors and challenges? How can we train employees to or anybody really to draw upon their experiences, their lived realities to offer emotional support and offer a safe space for those who are in distress to talk about without the fear of consequences, without breach of confidentiality, and also recognizing what is the extent to which I can provide support beyond which I have to now refer or nudge or encourage the person to reach out to a mental health professional, or also having these systems in place. And oftentimes, like I said, when we talk about stigma, there is also, what does stigma do? It leads to exclusion, it leads to discrimination, it leads to silence, and those are problems, right? So then having a grievance redressal mechanism in place that is actually functional, that is not tokenistic, where concerns are heard, concerns are addressed, and there is a feedback loop to ensure that these grievances are actually redressed. What are the feedback mechanisms that exist at workspaces? How are managers trained to be sensitive, to be empathetic, to actively listen? Some of these key sort of communication skills, how can it percolate across the institution? Because this is what then makes up that organizational culture, and it is what shows up at multiple levels, irrespective of where you are in that organization. We have done some of this through various projects, and happy to also chat both in terms of gatekeeper training or introducing peer support for workplace mental health, or even there's a lot of interesting work. I've been thinking about it for a while since we spoke about how the crime bureau records data, but there is also some interesting body of work around community surveillance and how we can strengthen data and this really kind of draws back to how all of us can play a role. You may not be ready, or you may not be in a position to immediately offer support. Is there something else you can do? And the answer is always yes. There are multiple ways in which individuals, employers, employees can support and play a part in preventing suicides. And I think, and this I think begets a larger discussion as well in terms of strategies and skills and all of that. But happy to continue that conversation.
Thank you so much. To really understand how stigma is a barrier, and if we have to firstly recognize it, how it really comes up in a one-on-one conversation, maybe even between a couple as well, right? Or how it can really come up in organizational space, or in the community space. Yeah, and I would like to really sum it up right in terms, because there are a lot of very interesting intervention strategies that are really coming from the organization space, and which is also most of the listeners also come from that space as well. So I think when you're looking at open culture for O, creating awareness, and when we're really talking about awareness as well, to really look at how are we really having these conversations. It's just not having a session on mental health, right? But really looking at the changes that one can notice that can indicate that an intervention is really needed as well, right? And that's like prevention starts much before that. Right, so if any changes in behavior, performance, drive, motivation levels, sleep, appetite, any kind of these changes that you're noticing, just reach out for help as well. And that's where support becomes very, very important. How are we really then creating support systems within our peer networks, with managers at the organizational level? Sometimes, support is also coming through infrastructure as well. When you're looking at neurodivergent folks, do we have sensory rooms, for example? Or the fact someone wants to be, like you said, that someone wants to be in a room sharing, they're traveling. How does that really then support? So how is the infrastructure really looking like as well? And that's what brings into the interventions part of it as well. When are we intervening? Who is intervening? Are they trained to intervene as well? What is happening to the data when they're intervening? So I think it's a very nuanced conversation, which has to be done with another eye of intentionality, right? Are we doing this with intention? So I think I itself is so layered as well. And coming out to S, which is a stress busting myths, what are the busting myths, and also the stress busters as well? And are they also going to be adaptable to the person's needs? Because there's no
Yeah.
one straight formula. One maybe works for one person, the other person may need something completely different at this point in time. Like I was talking to another client of mine and said that, I have so many voices in my head, not living with schizophrenia, but there's so many voices that I need to listen to, sit with my headphones with rock music playing. And when this rock music is playing, that's when I'm able to concentrate, because otherwise these voices in my head interfere with my work, right? As opposed to someone wanting completely quiet room, or needing certain sensory objects or tactile objects as well to be able to really ground them and soothe them. So we need to also understand that how needs are very, very unique in these situations as well. And while we are offering this, it's coming from a place of compassion, care, and not really talking about it. And that's why confidentiality becomes very important. We've seen people reporting that we did this for an employee in their newsletter, which is very counterproductive, right? So how are we doing it with compassion, care, confidentiality as well becomes very important. And again, if these things are not taking place, we have policies in place, but what if they're violation at the ground level, right? Then are the redress mechanisms put in place, like Chetna was also talking about? Are we really having this managers training now? We have a lot of mental health first aiders identified, and the separate training that happens for MHFAs also in organizations. Are we really training them on active listening, peer support? And these things becomes very, very important. But there are also very interesting comments that are coming in, so I'm going to really turn to that since we have about 10 to
Yeah.
12 minutes. I think one
Smriti,
question.
can I very quickly come in and add just one point here, which
Yeah,
is, I
please.
think, what you've also highlighted, but I just want to put a little more emphasis on it, which is that there is no one size fits all and there is no one solution for preventing suicides. And in the context of workspaces and just the principle and value which we hold very dear at the center also and practice, is the aspect of co-creating, is the aspect of understanding from people who you're supposed to be so-called benefiting, to say what is the actual need, how is the workplace and policies and practices actually contributing to distress. So the first thing of course is to acknowledge that it does contribute. The second thing is to say what are the actual needs, interests and preferences of the people, and then who is making the policy. Like in in the Indian context, there is a heavy underrepresentation of people from oppressed caste communities, people from vulnerable groups in leadership positions. So the policies are often made by, say, cis, upper caste, Savarna folks for people, and these policies and this sort of line of thinking will not be representative of those that the policies are actually impacting. So to really hear and co-create these programs and hence sort of contextualize it to the workplace, and it may look different for different workspaces and different groups of employees. And I know that it sounds like a mammoth task, but it really isn't. It is really about listening and creating that culture, and that includes, and that culture is shaped by the people. So recognizing what is working, what is not working, what are the challenges, what are we doing well, what can we do differently, and just co-creating that program, and co-creating those sort of range of interventions and solutions, I think is the way to go ahead.
Yeah. No, thank you so much, Chetna, for really talking about this as well. And I think it often gets skipped, right? That when we're building these systems, making these policies, it needs to have voices of the people with lived experiences, for who are going to be consuming those policies or using those policies as well. Right? So it's very important, and how we're really holding space for lived experiences to really make way when there is discussion happening around policies, around systems, the needs as well. And also, is there also space for a feedback that we did do this, but then perhaps it's not working, right? And this needs to be tweaked and modified and not be very rigid there as well, right? And again, then we're taking the agency and giving back the agency autonomy to the person for whom the policy systems have been created as well, which again I think is lies very closely to the Mental Health Care Act as well, that talks about this, right? That how you need to give that autonomy and agency back to the person for them to understand what kind of treatment they would also like, what kind of support they would also like as well. Right? So thank you so much for spotlighting this piece. I'm also looking at some of the questions that are coming in. I think I would like to pick up some of them because I think one question has also come about scale. That how do we conduct these trainings when you're looking at gatekeeper training, or we're looking at training for the mental health professionals as well? Because how feasible is it to implement these at scale in a country with a severe shortage of mental health professionals itself, severe shortage of trainers, right? How do we attain scale? Sachin, if you could answer that question.
Yeah, sure. I think more than scale here, right? We what doctor had mentioned earlier regarding OSS as well. It's about creating that culture. And one of the major, I'll talk to you about the challenge that I face, for example, right? When we have to provide this service to a corporate. So if we are able to plug in these challenges, I hope it will be much more helpful. Like, for example, the owners, the founders, the CXOs are not interested. This should be the first level of intervention that needs to happen, where the CXOs and the ones who are at the highest echelons, they need to be sensitized to what exactly this is, rather than, oh, I am at such a busy place, I am the one who has to handle all of these things, so you take care of my kids for me, I am fine. So what is happening? There is no seriousness being transferred from, top down. So it's extremely important that first and foremost, the CXO levels, they need to have this conversation. The awareness is extremely important at that level. I've seen effective intervention programs or gatekeeper programs have only happened in those places where the founders or the management levels have taken an active interest in that. And that has usually only happened when someone has personally had a loss to suicide. It's a very unfortunate sequence of events here. Until someone at a CXO level has had a personal loss, they are not invested in their organization getting this information. Otherwise, what I have to deal with as a trainer is, sir, आज 2 घंटे में खत्म कर दो ना. Just ऐसे क्या है, सुसाइड पे ज्यादा, वो सुसाइड बोलो मत ना. Don't use the S word, because it will make them all jittery and all. So first and foremost, if you're inviting or getting a trainer, let them do their job. Right? And probably one of the important things is you need to know what the hell are they talking about. So first get trained yourself before before you start thinking that, oh my God, I'm bringing someone who's going to say suicide 50 times in my organization. And as soon as he leaves, then 50 people are going to die because like what we understand about psychology is like everyone is impressionable. And what does that mean? If you say the word in front of them, then it's like Om Suicida and Namaha, and the person is now suddenly going to be suicidal everywhere. This is not what is happening. So the information, if it is being percolated right at the top management level, if the top management is coming out with their challenges and how they have taken support, because they do, right? I have seen people at CXO levels, they have psychiatrists help, they have psychologists help, they have therapists, at least three. Why aren't you talking about this, right? And and sharing with your team that, guys, I myself am going and taking this help. It has been absolutely fantastic for me. Why don't you go ahead and do it? This is not a sign of weakness. This is how you manage this modern digital mental age that we are part of. These are not like when we started eating sweets so much, we needed to upgrade our toothbrush and toothpaste. We had to have a dentistry mechanism available in that, right? Now we have increased digital and mental consumption. Like the way we are utilizing our mental resources is an extremely high level. And what we need is our brushing and our showering and all those things, our day-to-day habits, from a mental health perspective. We need to be able to have interactions with people who are professionals who can help me maintain, manage, or even become achieve my mental health goals that I may want to have. So having a bigger conversation, not just also thinking about mental health from the perspective that it's always something bad that is happening, right, with you. It's also, you can use your mental health to plan, to make a goal, to design your mental health requirements for the next few years on how you're going to achieve those goals. So it's such a broader topic, and not to create just a stigma that mental health means fighting stress. No, it's also about developing yourself. It's also about growing, and so. And I think the upper manage, if you're specifically talking about workspaces and management, it's extremely important that without the upper management investing their time and efforts in this, it does not happen. And to just give you statistics across the world, even though EAP systems are spreading very rampantly across the world, the utilization of EAP system is less than 2%. I'll reiterate, it's less than 2%. I'm talking about free counseling therapy that is being afforded in big organizations, even like your Googles, and at this high level. The utilization is extremely poor. So yes, the company can put in a good talk using their PR mechanism, but unless and until your Tim Cooks and your top honchos are actually going down on the ground and talking about their story and how these things have begun to help them, we really are going to struggle with an uptake amongst the workforce. Is one of my thoughts. Yeah.
Thank you, Sachin. And I think in the same vein, there were also two more questions, and I want to pose both the questions right now. So we know that it's very important for the CXOs to come and talk about this. In addition to having policy systems in place, access to EAP in organizations, people who are utilizing these services also to come and talk about it and normalize conversations around mental health. And it's okay to reach out for support, and how it's been supportive as well. We're not looking at them disclosing personal details, but just to talk about the experience, just like how I met this cardiologist or this GP or this nutritionist as well. I saw this mental health professional, right? But then we're also saying that, but the questions that are coming up in the chat is two. Do we even feel safe to say that we're not okay? And I think it brings it back to the stigma conversation, which is also internalized stigma as well. So if we can respond to that, that's number one. Two, what makes it challenging for people to reach out for support, even though when these systems are in place, whether we have the helplines numbers, trauma-informed professionals, EAP supports, they're already in place, but there's still more challenges. I think it's coming back to the conversation on stigma. But if I could bring in Chetna, Dr. Sangle, for your views on this one.
I'll quickly also respond to the first question. And I think the point about there being a severe shortage of mental health professionals, and to Sachin's point about utilization of EAP, what we do know is when in distress, people may not reach out to mental health professionals immediately, but they do talk to each other. And I think in a country like India, that is our resource. That social capital is our resource. And hence we are talking about peer support. Hence we are talking about utilizing lived experiences to in a skillful way to provide support and recognize, how can you support somebody. It's like first aid, right? Like, you don't go to a doctor when you can maybe just put a band-aid. And if you can actually recognize warning signs of distress when it is at that level where people are talking to each other and you can provide support, that really does solve a lot of the problem for a lot of people, right? So then that is where peer support and training across the workforce and across assistants come into place. um, I think your other question was, again, it is also to do with some things we discussed, right? Like, if services are available, are they accessible? Are they affirmative to lived experiences of people? Are you acknowledging the role of, say, caste, poverty, economic struggles, disability, lack of affirmative or inclusive policies, lack of, say, flexible working conditions in actually contributing to distress? And if the counselor or the EAP professional is not really able to do anything about it, then maybe the employee doesn't see a point in actually going and talking about it, right? That is one. And then, is it acceptable? Is it sensitive? Is it meeting you where you are at, and it is meeting your need? And then, what are the repercussions? Are there repercussions? I think there is also a lot of misinformation or confusion or questions around what does it really mean. Like, if I go seek support, how am I going to be looked at? And that is all of these things where stigma comes in, right? How do we view persons who are seeking help? How do we Are they penalized? Maybe not directly, but then their perception of them, the perception of how they're productive or how they're responding, how they're speaking, all of that may get affected. So there is a lot of fear of, I think, consequence and repercussions as well, which can prevent people from actually reaching out for support. Yeah, I'm cognizant of time. I'll hand it over to Dr. Sangli.
Yeah.
I think another thing of short one, a way of maybe managing the internal stigma would be the medical model of psychological issues. So, like diabetes is uh, the raised sugars in the blood, the hypertension is raised blood pressure. Similarly, all the psychological issues are medical illnesses. If the serotonin goes up, you have some issues. So, that's the diabetes of the mind. If you have dopamine going up, it is hypertension of the mind. So, a medical model of the psychological issues helps a lot. So, usually, the 2 or 3 standard examples that I give my clients is, so you're making a cup of tea. You need the sugar, the tea leaves, the water, and the milk proportion to be right. If it's not, you don't like the tea. Similarly, the brain has A, B, C, D. These are 4 chemicals. If the A goes haywire, you get OCD. If the B goes haywire, you have something else. So the brain is not liking the balance of A, B, C, D, E. So let's do the balance it right and get you a good cup of tea. So it's as simple as that. So it's a fracture of the mind. Unless you plaster it, it's now going to heal. So the pharmacotherapy is a plaster. And you remove the plaster and then you do physiotherapy. The physiotherapy is your psychotherapy. So please look at it as a fracture of the mind. You have a scooter which needs to work. You need the oil and the fuel proportion to be right. Otherwise, it's not going to kick start. So the neurotransmitters in your brain have to be correct. Otherwise, the brain can't kick start. So these kind of breaking it down to very relatable examples helps manage the internal stigma. The external stigma is a very big topic which we all of us have been going on and on and on about for since we have entered this field. But my target as of now would be to deal with the internal stigma with the person who's sitting in front of me. That can maybe contribute to the bigger picture gradually.
Yeah. Right. Thank you so much. And I think there's still so many questions that I have for all of you. But I guess we would need to have another conversation here to keep these conversations going. But I'm cognizant of time, so we already past 12:30. So I will take a moment to thank all the listeners for joining in and to all the panelists for being here. And just I think what I'm really taking away from this conversation is the fact that all the statistics that we're really talking about, they're just not numbers. There's a human story behind each statistic, one of pain, resilience, and the possibility of hope. So suicide prevention is just not a professional mandate and not a policy goal. It's a shared duty among all of us to care for one another, right? And the challenges that we're facing in India are far more complex, but they're not insurmountable. So together, if through in our homes, workplaces, communities, government, peer network, we can build systems and cultures that listen deeply. I think it's very important to listen. And also the example, like Sachin said, that don't make it about ourselves or external factors. Stay with the personal experience of pain. What is it that they're saying? What is the support they're really asking for? And then to respond with compassion and act decisively as well. Make referrals when you can't, right? So thank you so much just for being here, sharing your wisdom, and really having this conversation is a lot of care and intentionality as well. I think that's another word that's really staying with me, of intentionality of everything that we do. And I really hope this conversation is the beginning of multiple conversations so that real change becomes possible. Uh, so I would like to just let the listeners know that if there are these conversations that are raising some personal concerns, it's you would think you would like to reach out, please do. Support is available to you. In fact, all the panelists have agreed to also share their contact details with all the listeners, which we'll be putting out in the comments as well. So Dr. Jyoti Sangle, you could reach out to her for psychiatric consultations or clinical guidance. If anyone is interested in trainings, helplines, building listening capacity, please connect with the Connect Hut and Sachin. And in case you're, again, interested in trainings, but with research, youth empowerment, intersecting approaches to suicide prevention, Chetna here is your person and the entire team as Center for Mental Health Law and Policy as well. And for organizations, workplaces, HR leaders, if you're looking to embed mental health policy, equity, compliance systems, you could reach out to me and to my team at Equilibrium Advisory. So thank you so, so much for being part of this dialogue. And I really hope we continue to collaborate beyond today, right? And keep on having these conversations. Have a good day, everyone. Thank you so much.
Thank you.
Thanks,
Thank you for
everyone.
having us.
Thanks, Madhu.
Take care.
Thank you. Take care.